I finally agreed to this lecture because I think it tells a good story. This is my disclosure. As you can see, I have not spoken for Satellite Symposium until this pandemic, and so I have to declare my conflict of interest. So, at the moment, we have a full spectrum of therapeutics for COVID-19, as you can see. Pre-exposure, obviously, vaccine is the main arm, but monoclonal antibody. Post-exposure, monoclonal antibody is proven. Early treatment of high-risk patients, monoclonal antibodies, as well as a few antivirals, remdesivir, molnupiravir, and Paxlovid. And then for COVID pneumonia without oxygen, remdesivir. And then for more severe COVID pneumonia, you have remdesivir, dexamethasone, tocilizumab, paracetamol, and as well as monoclonal antibody. And now with mechanical ventilations, you have the same. So monoclonal antibodies are the first group of novel therapy that has proven effective, followed by the more recent antiviral. So there is a Singapore connection in this. And that's why I called it from patients to bench and back to the bedside. If you recall, on the 23rd of January, that was when the first case of COVID arrived in Singapore. Many of us got onto different international work groups. And at that point, we were talking about lopinavir, ritonavir, hydroxychloroquine, and what else. And so what a lot of us did was horizon scanning. And among the monoclonal antibodies in SARS and MERS, many of them were just preclinical. And the only company that has done a MERS antibody was Regeneron, and in phase 1. So we then decided to get in touch with them. So I was supposed to have a call with Regeneron on the 5th of February, but there was a surge of patients that went into NCID. I forgot about that call because I was busy admitting patients. And we had a second call 2 weeks later. After that, we had a material transfer agreement. You can see within less than 2 weeks, it was signed. And the first collection of the patient's blood was on the 12th of March. A second collection, just in case we didn't get enough cells, was about a week later. So essentially, they had courier on standby. The blood was taken and then was sent to Changi. And the plane flew out to New York and then was couriered to the headquarters of Regeneron. So essentially, they gave me a call, an email several days later to say they managed to get excellent number of cells out of the whole blood. We sent 50 mL per patient. And this science paper came out in June, about 3 months later, showing essentially a range of highly active monoclonal antibodies in the range of picomolar range. And what came to be known as Ronapreve essentially is 10933 and 10987. You can't really tell the difference here in the combination, but I'll show you later how the combination works. So essentially, they bind to different parts of the IgG1. So this is receptor binding domain, and this is 987, this is 933. So this one also shows you that this is live virus neutralization, this is pseudo-virus neutralization, and this is ELISA, that they are really quite active, okay? And at the same time they did this work, they also do mutational escape passage. You can see here that this is the probability of resistance from low to high. And this is actually, this is 417 and this is 484. These are the two sites that basically characterize beta, gamma, and delta on top of the 501 that was an alpha. And you can see that individually, the probability of resistance. So this is low dose and this is high dose. Individually, the resistance mutation escape is possible, but when you combine them, it reduces the possibility. So that is at that point, there was, remember this in June last year, there was no RBD mutations at that point. So in fact, there was a debate between the VIR CEO, who believed in the conserved SARS epitope, and the COO of Regeneron, arguing about whether you use 1 or 2 targets. And this one also shows the same thing about the, you can see that 987 seems more potent because there was only 1 mutation that reduces its EC50, whereas 933, there's a few more. When you combine them, there's no reduction in the IC50. Now, this is obviously not Regeneron's work. This is by independent group published in Nature recently. This is the Eli Lilly monoclonal antibodies. As you can see that delta is this red thing, is this color, and essentially belanimab doesn't work. Okay, and this is also the other one. Whereas for the 2 Regeneron monoclonal antibodies, this is beta. So beta is a problem for this, but not this. But for delta, there's no reduction in its in vitro potency. So the work done in June was borne out this year with the emergence of RBD mutations. So very quickly in October, the animal work came out. This is macaque. So macaque is a mild COVID model. This is prophylaxis, and this is treatment. This is placebo, low dose, high dose. You can see that it reduces the virus very quickly, but also importantly, you can see that the protection in the lung. This is placebo, this is prophylaxis, this is the treatment. So this is the mild COVID pneumonia model. And with hamster, they have the severe COVID pneumonia model. So they measure effects in hamster by weight loss. You can see here that there's no weight loss in prophylaxis because the hamster wasn't infected. But in treatment, there was slight reduction and improved. These are placebo, and also reduction in genomic as well as subgenomic RNA. So small animal and big animal non-human primate models. Actually, by that stage, they've already started their phase 1 trial. So now move on to the clinical trials. Now, while I wasn't really involved in the clinical trials, we did try to participate, but because COVID was so uncommon in Singapore then, Singapore didn't qualify as a site. But I was involved in reviewing the protocols with them for a while. So they were basically planning whatever studies you see now, post-exposure, eligible high-risk patient, as well as treatment of hospitalized COVID. So the first paper came out actually in August this year. So this is post-exposure prophylaxis. Now this is the second paper, okay? Essentially, if you give someone who is exposed in the same household, unvaccinated, within the first 4 days, you can reduce their chance of becoming infected by 81%, okay? So this basically went down from 7.8% to 1.5%. Now, of course, this happened, it was last year. This is before even alpha, okay? We know now, for example, in Singapore, unvaccinated household members, attack rate is about 25%, vaccinated is about 10 to 15%. But more importantly is, even though for those who became infected despite the prophylaxis, their illness was 2 weeks shorter, and viral shedding was about a week shorter. So it's a bit like vaccines, okay? If the patient breaks through on prophylaxis, their illness is milder, and the viral shedding is also shorter. So this is basically different categories. This is basically symptomatic infection, 81%. For any infection, it's actually a bit lower, about 66%, okay? This is about the reduction in risk for high viral load. This is about the shortened duration of symptomatic infection. And this is the shortened duration of high viral load shedding, okay? Now, of course, you know, if you ask about should you be giving this to people, ideally you should be vaccinated, okay? But if you are unable to be vaccinated because of allergy to all vaccines, or your immune system is very bad, and even with vaccination you don't seroconvert, booster prophylaxis can be effective. Their first paper actually came out in December last year, which is the early treatment of high-risk patient. And this is their phase two, which is just 275 patients. So in the phase 2, the primary outcome is the viral load. And this was not very impressive. It's 0.5 log. But what it shows is that in the placebo group, 6% will progress to the need for hospitalization. Predominantly is the need for oxygen. And 3% in the treatment group, okay, a little high-risk patient. That's 50% reduction. So that actually is not as impressive as some of the other early treatment trials. So this is low dose, high dose combined compared to placebo. You can see that the reduction is about 0.41. But importantly, Regeneron started out planning to test seronegative and seropositive. So what it shows here is that if you're seronegative, reduction is 0.56, but if you're seropositive, it's 0.21. Okay, so that underpins the use of monoclonal antibodies in COVID patients. If you're antibody positive, whether it's CPAS, neutral antibody, Roche S or N antibody, as long as it's positive, the benefit is much diminished. But this is virological data. And this is in terms of hospitalization. So once again, low dose, high dose combined, placebo. This one is reduced by 50%. But if it's antibody negative, it went from 15% to 6%. Okay, once again, a higher magnitude of benefit. Actually, their phase 3 trial was released on the preprint in June, but somehow it still hasn't come out in the journal. The reduction of hospitalization is actually 71% once they analyze 4,000 patients. Okay, and the illness is also shorter by 4 days. So this information was not available in the phase 2 trial. So it has quite a few endpoints. This is the high dose, this is the low dose, and you can see that the reduction is very similar. So you can use the lower dose. And this is for high viral load for the high dose, and this is for antibody negative. And you'll see that the benefit is even higher, 77, 76%. This is for the low dose, high viral load, and baseline antibody positive. And you can see that if the antibody is positive, the reduction is about 80%. Okay, and time to resolution as well is shorter by about 4 days, whether it's high dose or low dose. So you don't actually need to use the 2.4 grams, it's only the 1.2 grams. So this pivotal phase 3 trial surprisingly has not been peer-reviewed and published. So in terms of, just to show you the subgroup analysis, you can see here that for high viral load, both doses work. For seronegative, both doses work. But for seropositive, you can see that possibly the low dose doesn't work. Okay, so the way we use the antibody is basically you can get the antibody back within the same day, and we will not give this if the antibody is negative, it's positive. Now, then you may ask this question. With all this new treatment, they're expensive. Is it really worthwhile? So this is some work done by Alex Cook and his team, Mina Park at the School of Public Health. And what we did is basically looking at several scenarios, people in their 50s, 60s, 70s, and 80s. Scenario 1 is nothing. And then we look at treatment of high-risk patients with T or prophylaxis, and if they break through, we treat them, and look at different age groups. And this is the cost per severe case averted, and this is the cost per life year gain. So actually, even though the drug is expensive, in fact, is cost savings in early treatment of high-risk patient is actually cost saving. It's not even, you don't even look at cost effective, it's cost saving. And for the others, in terms of prophylaxis, so for example, if I give it to everyone, the cost per life year gain is only 13,000, and this is considered very cost effective, okay? Internationally, you can look at 30 to 50,000 per life year gain is considered cost effective. So what determines how you use it really depends on, do you have supply, and how much you are willing to pay per life saved. So this work is still under review. Now, so I've now demonstrated to you that it works in post-prophylaxis, it works in early treatment of high-risk patient, and this is Regeneron partnered UK recovery group, and so this is an independent study. Okay, Regeneron's own phase 3 trial in hospitalized COVID has not been published or as preprint yet. What we know is that it probably didn't work in the intubated patient because that particular group, there was, after interim analysis was stopped. So we are waiting for ongoing data from Regeneron's own phase 3 trial at low flow and high flow oxygen. But recovery trial released this in June this year, and compared with usual care, there's reduction in mortality by about 20%. So tocilizumab on top of steroid reduces mortality by 15%. This one is 20%. And these are the usual endpoint in terms of progression to ventilation, duration of an oxygen, as well as death, and it was all significant. Importantly as well, if it's seronegative, it works. Seropositive, it doesn't work. And same thing here for invasive mechanical ventilation, okay? But of course, the dose used here is 8 grams, so it's about seven times higher the dose. How about real-world data, you may ask? So this is some work out of US. Essentially, they looked at hospitalization at day 14, 21, 28, ICU admission at the same time points, and death at the same time points. This is the Ronapreve, and this is the control cohort. The way they present the data is a bit strange, but this is basically 2% at day 14, 2.9 at day 21, and 3.2 at day 28. So when you look at this versus this, essentially you are looking at this versus this. Yeah, it's about 6% reduction. Okay, there's no difference in ICU admission, and there's no difference in the mortality as well. So there's some real-world data that is consistent with the clinical trials. So this is a very short story of, we weren't really, our main purpose of collaborating with Regeneron was actually to try to get the clinical trials to come to Singapore. They didn't want to, and to get early access. So as soon as we heard of some of the data, we engaged the company, and as many of you know, we do have Regeneron, the Roche Regeneron Ronapreve in Singapore currently. So that's all I have. Thank you for your attention.
Thank you, David, for that very insightful presentation of Regeneron and where it stands at the moment and what is outstanding with regards to the phase 3 trials. So since it's been used in Singapore and NCID has the major proportion of all the cases of COVID, how has the results been with the usage of Regeneron in Singapore, especially in NCID?
I have to say we haven't analyzed it yet. And the number of patients treated is not high. And but of course, data have been collected and will analyze in due course. I mean, it's important to remember that the risk of progression is not high, and it doesn't reduce it by 100%. So at this stage, what we're trying to do with a few thousand patients every day is to identify the high-risk patients. We mostly use the ISARIC score because if you actually look at the criteria they use in the trial, is actually very broad. Like if you're above a certain age, you can get it. And we know that there is a variation of risk, all beings equal. Things like gender, comorbidity, and so on. So at this stage, the way we prioritize the use is the ISARIC score, and the risk obviously is a bit higher in our patients compared to, I can only tell you that from the first look, our risk of progression is higher than the trial.
Okay. What about the use of Regeneron in the prevention of COVID on an ambulatory basis? Has that been used?
Well, I mean, in Singapore, what is being planned is that medical countermeasures can be started in the community treatment facilities.
Yes.
So these are the enhanced community facilities where there are doctors and nurses, and if we identify the patients with high risk using the ISARIC score, then we'll actually give this to them. Now, although this can be given in primary care, say in the US, we have not done that here because if a patient is positive, they tend to be either isolated at home or they are sent to the community facilities in order to reduce community transmission. So even the US, the other mode of use is actually to give a shot of this in emergency. Now, obviously, our hospitals are fairly full, and we do want to avoid people going to emergency who do not have an emergency. So our current plan is basically to give it in the community facilities as well as in the hospitals when we encounter such patients.
Okay. So far with the patients that we've treated with Regeneron, has there been any side effects, any allergic reactions?
Yeah.
Observed?
So, it is a monoclonal antibody, so one should always be cautious of infusional adverse reactions as well as anaphylaxis. But actually, in the worldwide database, anaphylaxis is actually exceedingly rare. Having said that, the use of monoclonal antibodies, whether it is Roche or GSK, is not as widespread as vaccines. So that the denominators is not like vaccines. It is actually very rare. We have not had anaphylaxis in hospitals, but because such a rare event, I doubt we will see it until we use a lot more of it.
Okay.
So we still advise close monitoring for an hour post-infusion and give the patients the appropriate advice about calling for help if they become unwell after that.
Thankfully, it is not the anaphylaxis risk is much lower than, say, some of the vaccines that we've given, where we really see it, anaphylaxis starting off within the first 30 minutes of the vaccine injection. David, perhaps because we've got a lot of doctors here, and some of our doctors may be actually involved in the management of cases in the COVID isolation ward. How would you advise them with regards to identifying a patient suitable for Regeneron?
I think number one is to identify the high-risk patients, and we know that in COVID, age is a major risk factor. So, I mean, if you look at our data in Singapore, in the unvaccinated, age above 60, you start to see a lot of ICU and death. In the vaccinated, it is really in the 80s. For the vaccinated, I think you can still consider it, but you must look at the antibody. I mean, there will be people who are vaccinated with 2 doses, even 3 doses, who don't mount antibody response. And these are usually the people with immunosuppressive conditions, such as cancer, transplant, or rheumatologic conditions. And but among the comorbidities that are more important, I would say diabetes and renal failure, and to a lesser extent, hypertension, as well as conditions like heart failure and chronic lung diseases. So I think by and large, if you look at these populations and you count the highrisk score, it will be high, and these are the group that will be worthwhile to treat early.
Well, I mean, just to steer away a little bit, we anticipate, of course, some other newer antiviral agents that will be available for the treatment of COVID-19. One of these will be Molnupiravir. And I'm just wondering, what are your thoughts about this antiviral drug, which is oral?
I think the antiviral drugs are definitely a game changer. Especially they will be able to be given outside of hospitals, but there are several differences. Now, all the trials actually, if you look at whether it's the Ronapreve trial or the Paxlovid trial, they actually excluded patients who've been vaccinated. But because the antiviral doesn't work through antibody, presumably it will still work if your antibody is positive. So that's number one disadvantage. But you must also remember that not all antiviral early treatment is the same. So for example, Molnupiravir, the reduction in progression is 50%, Remdesivir is 81%, and the Pfizer 3CL protease inhibitor is 89%. So they are varying frequency, but also drug interactions. So, I mean, if the protease inhibitor from Pfizer, for example, has ritonavir in it, so you have to watch quite a lot of drugs that interact through the cytochrome P450. Remdesivir, by and large, doesn't have drug interaction, and neither does the monoclonal antibodies. So I think there are a lot of considerations, and this could be a gamut of interventions that doctors can use. Of course, the convenience of oral versus IV, I think a lot of patients will prefer oral. But at the same time, this is one injection, you forget about it after that. Whereas you take the oral antiviral for 5 days, and it's actually quite a few tablets. The data just came out a few days ago that even though the expected effect is about 3 to 4 weeks with this sort of unmodified IgG1, but actually the protective effectiveness of this antibody, Ronapreve, has been observed up to beyond 4 to 6 months.
Yeah.
So I mean, that really deserves a closer look. It is not meant to last that long, but somehow it has been shown to have residual effect.
So I think for those who are unvaccinated, who are seronegative with regards to COVID-19, it is a plus point since the duration of effective activity is in a matter of months. Although there isn't a definite study following up on this. I hope Roche will be doing further studies on it.
Yeah, this is the information I shared was mentioned in Netscape, and it was just a follow-up of their phase 3 trial.
Okay,
yeah. Yes.
Right. So I think that is, we didn't have any other questions from the floor. I suppose because this Regeneron is still quite new, and like you said, we haven't treated that many patients in Singapore with this particular cocktail of monoclonal antibodies. But it's definitely, like you said, something to look forward to, especially since it's got a long duration of action, and especially those who are not vaccinated. And as you well know, a lot of our patients are old, elderly, and partially to non-vaccinated. So I think if we do not have any other further questions, we will call the session to a close. Thank you, David, for that very concise presentation on Regeneron.
Thank you.
Ronapreve. Thank you.